I'm Shumakra Chaudhary, and this is today in this special colloquium. People who are familiar with our colloquium series know that from time to time we stray from our regular topic of physics and astrophysics. And here I'm very happy to say that we have brought in somebody from outside our domain to speak about something very topical right now. We are going to listen to a talk today about COVID-19 and various issues related to it. Today, our speaker is Dr. Sayantan Banerjee, who did his PhD, who did his medical degree in Kolkata Medical College in Calcutta, and then his MD in Delhi in Maulana Azad Medical College. His DM, which comes after his MD, in infectious diseases from AIIMS, and he worked at AIIMS Delhi until recently, and now he is an infectious diseases physician with special interest in antibiotic resistance, biosecurity, dangerous pathogens, i.e. all very relevant right now. He works now at the World Health Organization, WHO Southeast Asia Regional Office in Delhi. Now, he has emphasized today that he is speaking today at his personal academic capacity, and he's not representing WHO or any organization. And we have told him that he reserves the right to not answer any questions that might not be relevant to his expertise, or also might be construed as coming from somebody who's in an official position. Okay, we will have a set of question and answers after his presentation is over. I would request everybody, and I'll make that request again at the end of the talk, to keep the questions to the topic as well as to the expertise that I talked about. Dr. Banerjee has said that we thought we might be able to use that whiteboard, but we can't really. So he has a few slides on PowerPoint, which he may or may not use. And I am very happy today to hand you over to Dr. Banerjee. You can start now. You have to unmute your microphone first. I think you're muted.
Yeah, this is the typical thing that happens in all the Zoom conferences that I am attending. Sometimes I unmute, sometimes the host mutes me. So it's always like that. So thank you, Professor Chaudhary, for inviting me to this colloquium. And it's probably my first colloquium, my first talk to the group of most learned astrophysicists and astronomists of the country. I have never spoken to astronomists before. So this is a rare opportunity. I'll try to make myself lucid and understandable as much as possible. And definitely you have your liberty to stop me and ask me if somewhere I'm going haywire and nobody is actually understanding my jargons. Okay, so yes, I'm Sayantan. I'm currently working with WHO, but I would like to explicitly say that today I am speaking on my own behalf. I'm not representing my organization, World Health Organization, right now. And whatever I'm talking is my personal opinion based on scientific and academic facts that are present. Okay, so I would try to avoid as much as technical things possible in terms of biomedical and immunological and medical perspectives. And I would try to keep this talk limited for the understanding of non-biologists. Okay, so one of my friend who is not a biologist, who had his degree from IIT and now became one of the administrators of the Indian Administrative Service, he told me that what is so special about coronavirus? You know, I haven't heard of the name of coronavirus like 4 months back. And today, everybody, everywhere it is, in all the continents and in all the street corners, everybody is talking about coronavirus. So what is a specialty? What is it? in a few nutshell. So what I believe is everybody has started Googling, everybody is reading a lot, and nowadays we have a huge, explosion of information in the internet, in the social media, in the mobile phones, in the chats, and all the inboxes that we have in our mobile phones. And it's so difficult to keep up. Okay, so I would just, in a short nutshell, I will just talk about what is coronavirus. So as the name implies, corona comes from crown because of the appearance of the virus, how it looks under the electron microscope. Okay, and it's a virus. So essentially, it is an intracellular organism. It cannot replicate outside a human cell or an animal cell, the host cell. Okay, this is number one. Number two is, coronavirus has been known to the history of mankind for quite a few decades now. And most of the coronaviruses are simple, very simple cough and cold causing viruses. So there are about 7 coronaviruses. I'm not going into technical jargon. These are available across the internet. So out of which almost 4 coronaviruses keep on circulating in the, I'm sorry. Yeah, so there are a lot of chats coming out. I'll just, Professor Raichaudhuri, if you just want to tell me anything, you can just come in and talk, huh? Because a lot of chats are coming out.
Can you just remove the chat?
I'm removing it. Yeah.
If you click on the chat window, the chat window goes away.
No, I've closed it. I've closed it. I just kept it open in case you need to communicate. Okay. So coronaviruses are typically simple cough and cold causing viruses. There are 4 strains of coronaviruses which causes cough and cold in the human society throughout the world, throughout the year, and hardly it causes any serious disease. Okay. Now, if you see, I would like to share my screen here. So yeah. So if you see that 10 to 30% of all the upper respiratory tract infections globally are due to coronaviruses. Okay, there are many other viruses like respiratory syncytial virus, there are rhinoviruses, which also, and adenoviruses, which also causes this cough and cold. And largely because of the worsening air quality, both indoor and outdoor air pollution. Outdoor air pollution is all because of this, the PM 2.5 floating around, because of the fossil fuels and other reasons. And indoor air pollution is mostly in rural areas and in urban areas where we don't have a clean fuel, where still solid fuel is used as for cooking, and because of smoking. Okay, so what I was trying to tell is, because of increase in pollution, there are more and more symptoms resembling upper respiratory tract infection among children and adults, which are confused with the viral infections. So we have a lot of common cold-like symptoms: stuffy nose, running nose, sneezes, cough, even a little bit of malaise and low-grade fever with pollution. And rest is mostly with other viruses. Out of all the viruses, about 10 to 30% are due to coronaviruses, which are absolutely not significantly harmful, which has almost nil mortality rate. And these are the viruses which showed us that we don't need to bother too much about coronaviruses. We were not bothered until 2002. So what happened in 2002? There was an outbreak of severe acute respiratory syndrome, where almost 30% of people who got infected with this respiratory syndrome, which exactly started with similar features like that we have here during this COVID outbreak, that is fever, running nose, stuffy nose, a little bit of cough, progressing to dyspnea. Dyspnea means shortness of breath, and then the shortness of breath increases, the respiratory efforts are more and more needed. When the person fails to comply with the respiratory need of the body, then we need to intubate him with a mechanical ventilation to carry out the respiratory function. So this persons infected with the SARS viruses in 2002, almost 30% required mechanical ventilation and 10% died. This was the first time when the scientific community was scared of coronaviruses. And this was named as SARS-CoV. It started again from China. And studies have shown that SARS-CoV virus is probably has originated from animal sources, because at least 3 animals were found where SARS-CoV viruses, exactly equivalent virus, was found in the human beings as well as those 3 animals. One of those were the masked palm civet. Okay, it's a kind of animal which is otherwise not consumed widely worldwide, but has been a traditional wild delicacy in China, masked palm civet. And it was also found in another group of animals called raccoon dogs and ferret badgers. So these 3 kind of wild exotic animals, mammals, which some group of people in China has a test for these animals. These animals were used as for consumption. SARS-CoV were found in these 3 animals, and it spreaded. The one thing which was less in SARS-CoV and is more in this COVID-19 is the transmissibility, the human-to-human transmission. But you can clearly see that with the 10% mortality, SARS-CoV was at least 2 to 3 times more death-causing than the present COVID-19. Next came in 2012, the Middle East Respiratory Syndrome coronavirus, the MERS-CoV, MERS-CoV. The MERS-CoV again presented with similar kind of atypical pneumonia, that is initially upper respiratory tract infection, then fever, then cough, then shortness of breath, associated with kidney failure. AKI means acute kidney injury, where the kidney rapidly, the kidney function rapidly deteriorates. Along with that, there may be some sort of gastrointestinal symptoms, and the mortality of MERS-CoV is much more higher. It's somewhere around 30 to 36%. And interestingly, MERS-CoV, the virus has been isolated, as well as the antibodies, that is the response against the virus, has been found in camels, in dromedary camels, in the single-humped camels of Arabia. And it has typically infected people who gathered for the Hajj pilgrimage because of the overcrowding that's happening over there. And then it was also not so much human-to-human transmissible, so that it didn't spread across all the continents, and it didn't attain the magnitude that we have today. Okay, so now in 2020, we have this novel coronavirus. I won't go into too much of this detail, and I would come back from sharing screen. Stop share, yeah. So now, what is special about this coronavirus? When this coronavirus started, we didn't, all over the world, the infectious disease physicians, the public health practitioners, and particularly the politicians, didn't take it seriously in the beginning, because we thought that it's a 3% mortality disease. It's not like smallpox. That's a 30% mortality disease, okay? And it's R0. I'll come and explain what is R0. The basic reproduction number, that is how many people get infected from one person, is somewhere around 2 to 2.6. You know, we have dealt with diseases with R0 like 10, 15, like smallpox, like measles. These are diseases with very, very high R0. I'll come and explain what does I mean by R0. So initially we thought that we have a disease of R0 2 to 2.6 and a mortality of 3%. It won't be affecting too much. We don't know how much it is transmitted. It's not airborne, it's only droplet borne. I will explain what do I mean by droplets, okay? So we thought that it's not going to be big, but it became big by the sheer factor that it is highly transmissible. It is less transmissible than Ebola or measles, definitely, but The only one thing that is important for coronavirus, which differentiates it from Ebola or measles, is the clinical features may be very subtle, and it can be transmitted in the pre-symptomatic, asymptomatic, or mildly symptomatic stages. Whereas if you have a disease in which you have, red spots all over your body, and you get jaundiced, and you have so much symptoms like Ebola, or you have vesicles like smallpox, so that people can recognize that you are infected from far away, then the propensity of transmission comes down. Okay, even if it is highly infectious like Ebola, the chances of contact comes down. If you have a more part of the disease which is asymptomatic and mildly symptomatic, people are not scared of coming in contact with you because you're hardly symptomatic. You are just sneezing 5 times a day, a little bit of feverishness. So everybody can come in contact with you, So that's the reason for which coronavirus, COVID-19, spreaded a lot. Now, let's come to it. How does it cause disease? So what do I mean by airborne and what do I mean by droplet? So it's to keep it very lay, to keep it very simple, I would say that if the bacteria or the virus, if the germ is suspended for a longer time in the air and can be transmitted to a farther distance, longer distance, without the need for having heavier carriers, will be airborne. Okay, let me explain. What do I mean by heavier carriers? So whenever, coronavirus is all the viruses are intracellular viruses, okay? So whenever you sneeze or cough, you give out a number of droplets which are invisible to the naked eye, or sometimes visible even, it's such big, and can be seen even by a hand lens or a small low power microscope, which contains salivary particles with squamous epithelium or the respiratory epithelium laden with the viruses. Now these droplets will go out, and as these are heavy particles, it would gradually settle down, except for a few circumstances that the recent reports has shown that if there is aerosol generating procedures done and the droplets are broken down into small particles in a closed room, then the coronavirus can be airborne and can be transmitted via air beyond the usual transmissibility of the droplet sizes. Okay, recent studies have shown that. I will come to it. But normally it means that if you just cover a cloth on the person, of the person who is sneezing, or if you are away from that person so that so many droplets doesn't come to you, or you cover your cloth, or you cover your face with the cloth, or even if you touch those droplets and you wash it off, because the droplets cannot go in through the skin. The droplets, the virus, can only go in if you touch it in your intact skin, and then you somehow touch your mucous membrane. This is the mucous membrane. This is the mucous membrane in the eyes. Okay. Where the live virus is there. Okay. This is the only way how it can get transmitted. Now, if you wash it out with a soap and with an alcohol sanitizer, the virus dies. So this was the thing. But later studies showed that there are much more serious problems associated with it. When the patient goes bad, suppose a patient develops severe acute respiratory distress syndrome because of bilateral pneumonia caused by this virus, and he comes in the hospital emergency, then this person might need mechanical ventilation to assist the need of respiration. Okay, so in that case, an endotracheal tube is inserted in the trachea of the patient while the patient is lying down. Then a suction machine is used to clear off the secretions from the airway, and a mechanical ventilator is attached to the endotracheal tube. So this entire procedure has some steps where there is aerosol generation because of sudden vacuum creation and sudden pressurization of air. Okay, so this aerosol generation actually breaks down these droplets and keeps the virus suspended if it is a closed room. You know, nobody usually intubates in an open space outside the hospital. We do it inside the emergency. Normally, we do it inside the emergency, which is a closed space. So once this mechanical ventilation intubation is done, the virus can get suspended in that closed space and can remain suspended for over an hour and can actually transmit the disease to anybody who is coming into that room and is not taking appropriate precaution. Appropriate precaution means not simple surgical mask or not simple covering of your face as it would have been in normal droplet precaution. But in that case, you have to have a proper medical grade N95 mask. I would come back to it. Now, let's come and understand that why people die of coronavirus. Okay. So what happens is, whenever the virus comes in, it gets attached to the respiratory epithelium. Then it starts entering into the cells, it starts replicating, and then it comes out, bursts from the cells, comes out, infect other cells, keeps replicating, then again bursts and comes out. In the meantime, your body's immune system comes and recognizes the virus and then produces antibodies and T cells, okay, to fight against the virus. So there is a fight going on between your immune system and the virus. If your immune system starts losing the battle, then the virus starts gaining and more part of your respiratory tract is infected and you gradually succumb to the disease. And if at a certain point of time, if your immunity starts winning, the number of viruses replicating gets gradually killed and you eliminate the disease. Somewhere in the equilibrium, if you have an effective medicine coming from outside to support, to kill the viruses, or if you have an effective supportive therapy coming from outside, where it gives you time for your immune system to catch up in the disease process, then you have more time and your body gets a bit more advantage over the viral reproduction. Okay, what happens if, suppose I have very less immunity and I get infected with the virus? Then the virus can infect the lower part of the airways, the trachea and the alveoli, and gradually it would damage the respiratory exchange membrane. Okay, so if I use physics terms, it would be more easier for you guys. So whenever we take in air, the oxygen gets diffused into the blood against a wall in the alveoli. Okay, where there is the respiratory epithelium, inside there is the blood vessels. Okay, so if this respiratory exchange membrane becomes opaque and damaged, then despite you take in oxygen, the oxygen doesn't go in your blood. Okay, so this is called a mismatch of the inspiratory oxygen versus the percentage saturation of oxygen in the blood. Okay, the percentage saturation of the hemoglobin in the blood. Okay, so this mismatch, in medical terms, we call it a mismatch of PF ratio, the PaO2, the oxygen in the blood ratio, versus the FiO2, the inspiratory fraction of oxygen. So if we have a substantial part of the lungs damaged, the PF ratio will gradually creep up, and despite of giving more and more oxygen, suppose now we all are breathing in 22% oxygen that is there in the air. Okay, now when we have our damaged lung, to maintain the oxygen saturation, we need to give more oxygen, 30%, 40%, 50%, 60%. And gradually, if our lungs keep on getting damaged, despite of increasing the oxygen, your oxygen saturation in the blood might not attain the desired level. And the vital organ oxygen supplies to the brain, to the heart, to the liver, to the kidneys might actually fail. So this is the situation which happens. And this condition is known as acute lung injury, or ARDS, acute respiratory distress syndrome, depending upon the grade of severity, that how much of your lung is damaged, so that despite of increasing the oxygen in your inflow, in your inhaled air, the oxygen is not coming to your peripheral circulation. Okay, so this damage gradually kills a person if the respiration is not assisted from outside. Now with mechanical ventilation, what do we do? With mechanical ventilation, we try to increase the oxygen concentration, plus we try to decrease the load of the exercise of respiration. You know, at a time when you need to breathe too hard to let in more and more oxygen, your respiratory muscles fatigue. Okay, and as it is getting less and less of oxygen, because you know the blood supply of the respiratory muscles are also carrying less oxygen, so they are getting more and more fatigued. So you enter into a spiral of dipping down. Okay, so here comes in the mechanical ventilation, which gives the pressure, recruits the alveoli which were being collapsed because of the infection, recruits those alveoli, gives more oxygen and reduces your work of respiration. This is when the mechanical, this is how the mechanical ventilation helps in case of ARDS. But you know, there are certain limitations to it, and it's a very delicate procedure. You need to maintain all the oxygen fractions and the tidal volume and the post-expiratory, end expiratory pressure and everything. It's really, believe me, it's a really complicated game inside the ICU with the ventilators. So if you see the data, the mortality data of severe ARDS in India, published from all the big tertiary care centers like AIMS, like PGI Chandigarh, like CMC Vellore, like KEM in Mumbai, between 2016 to 2019, irrespective of COVID-19, just remember there was no COVID at that point of time. Irrespective of COVID-19, the mortality rate of severe ARDS in India was somewhere between 50 to 60%. It's quite high, okay. And 15 years back, it was somewhere around 75%, despite of best ventilators and ICUs. There is a little bit of referral bias as well, because in our best of the centers, people are referred from many other hospitals and nursing homes and reach late. But despite of that, 50% mortality is almost the rule for severe ARDS. Now consider COVID-19. Okay, in COVID-19, out of 100, almost 6 to 7 patients go bad. Now, if you see the statistics now worldwide, the mortality is somewhere reaching to 6 to 7%. But there is a caveat. There is some problem with the denominator. Probably we are not being able to test enough. But if you see the initial epidemic curve and quite till last 1 or 2 months, the mortality was stable between 3 to 4.5%, and the worsening of cases were somewhere between 6%. So if you consider 6% of cases in India going bad, despite of our best ICUs of AIMS, PGI Chandigarh, etc., the mortality of severe ARDS will be 50 to 60% of this 6%. So this is the catch where we have to understand that if people start entering into the 6% black hole of worsening, despite of having best ICUs and best ventilators, we are not going to reduce the mortality substantially. This is the point where I started worrying the most, because I'm much more comfortable with ventilators and ICUs than public health measures to reduce the number of cases. But this is where I understood that probably we have to come out of the ICU and we have to think beyond the ventilators for actually reducing the mortality related to COVID. So how can we reduce this burden? So this burden can be reduced primarily by reducing the transmission. Okay, so as you are all astronomists and astrophysicists, I'll give you, I was wanting to use the whiteboard, but I won't use it as it's not very well visible. I'll just try to give you a little bit of brief. See, there is a concept called R0 in transmission. R0 or R0. Okay, this is called the basic reproductive number. This means, suppose a new disease has entered a group of people. Okay, and this group of people are all susceptible to this disease, like COVID-19. Nobody has immunity to COVID-19. Now, if this new disease comes in, how many persons will get infected from each person? Okay, so this R naught is actually back calculated by studying an epidemiology in a given situation. We see that one case was inserted in that population. After 1 month, okay, we see this many number of cases, and then we back calculate it with some mathematical equations, and we try to find out that on an average, how many persons are infected from one single person. Okay, now this R naught, in case of COVID-19, is typically throughout the world, at least 2 weeks back, it was somewhere between 2 to 2.7. Okay, this 2 to 2.7, let's take a number in between, 2.5. This means that one person, if introduced into a population, will infect 2.5 persons. This will again infect 2.5 persons each, and it will exponentially keep on infecting 2.5 persons. And on an average, it is said that in 1 month, there is about 6 generations of infection. So from one person to other person, this comes to an average of 5 days. Now, just all the mathematicians here, just calculate that what will be the total number of cases if the R naught is 2.5. For 1 month, we have 6 generations of transmission. The number will be 1 plus 2.5 plus 2.5 square plus 2.5 cube plus 2.5 to the power 4 up to 2.5 to the power 6. Am I clear? This will be the total number of cases in 1 month from one case introduced into a population. Because I'm telling that on an average, the gap between these are 5 days. Okay, between each generation, and in 1 month, we'll have 6 generations. Okay. Now, if you add this one up, this comes to this total number of figures after 1 month from one case will be 406. Okay. Now, this is a real figure. Okay. So that means that one person can cause 405 more new cases of COVID-19 if introduced into a population. That's the worry. Okay. And now consider why people are talking about stay at home, isolation, social distancing. Why people are talking about this? People are talking about this because if normally I meet with 10 people, okay, or 20 people per day in close contact, if I just meet half of the number of people, if I just cut down my transmission rate to half, if all these people does not meet closely with other people and just cut down their transmission rates to half, then what will happen? Then the R naught will become 1.25, right? Agreed? The R naught becomes 1.25. So this value after 1 month will become 1 plus 1.25 plus 1.25 whole square plus like up to 1.25 to the power 6. You know, the problem with the medical people and the problem with our many of our lawmakers and decision policymakers, they are not good at mathematics. Okay, and I bullied them a lot with this. You know, I asked them that just tell me what can this value be if you have a half R naught, and it will be 1.25 plus 1.25 square, 1.25 cube, instead of 2.5. This value adds up to 406. Tell me how big will this value be? So everybody would say, anybody, any volunteer, or it would create chaos. Okay. Okay. So you are brilliant astronomist and astrophysicist, so you will definitely hit the bullseye. So most of my IAS friends, most of my policymaker friends, most of my medical friends told me that it will be somewhere around half, somewhere around 200, maybe 150, 200, something like that. But if you really add this up in your home, you'll find that just lessening the R naught to half will make this value only 15. Only 15. Instead of 406, this value will come to 15. So this is the beauty of social distancing. This is the beauty of quarantining. This is the beauty of staying away, not meeting people during the epidemic. Okay, you just do this as your homework. Okay, so now I come to what should be done and how we should go forward with the disease, and why I am telling that ICU and ventilators are not the solution for COVID-19. Rather, community interventions are the solution for COVID-19. Primarily, it's because of this. Secondarily, it's because that, you see, worldwide, policymakers have realized the gravity of the disease late. Unfortunately, the Prime Minister and the Prince of UK got infected, the Health Minister of UK got infected. But initially, the Prime Minister of UK thought that it's not a big disease, we'll keep on shaking hands and all. But you saw it was a bad thing that happened. But India has taken very appropriate steps from the beginning by saying namaste, greeting by folded hands and not handshaking, by implementing a lockdown, nationwide lockdown very early, okay? And by showing wonderful diplomatic skills, by airlifting 645 Indian nationals from Wuhan from the middle of the epidemic, and also helping many other countries by providing diagnostic kits, by lifting their citizens from China, etc. Okay, but if you look now, in the middle of this lockdown, what is happening is the initial cases were all initial imported cases. Okay, the initial imported cases were from maybe China, from Italy, from Dubai, from Spain, from Iran, from Thailand. These initial imported cases were tracked and their contacts were traced. There are incidents like some singer going and marrying with people despite of getting the diagnosis and spreading the disease. There has been stray incidents like this, but mostly their contacts were traced very actively by the government. But what were missed were the invisible contacts of the initial imported cases. These invisible contacts are the invisible service providers of our society, whom we tend to ignore, whom we actually just don't see, who are invisible to us, like the housekeeping staff of the aircraft, the airplane, ground clearance housekeeping staff, the housekeeping staff of the airports, the washrooms of the airports, the housekeeping staffs of the hotels, the Ola, Uber, and all these cab taxi drivers, the maids and the domestic helps of these initial imported cases, the commercial sex worker sisters of us, the other people like the close caregivers, like the saloon workers, okay, mostly the cooks, the bartenders, who came in close contact with the initial imported cases before the lockdown. And what we have seen is these close contacts of the initial imported cases are mostly working in unorganized sectors, informal sectors. Many of them are daily wage laborers or monthly wage laborers in informal sectors, and they don't come from a luxurious household. Lockdown means social distancing for you and me, who have the luxury of getting ourselves locked down in an apartment and logging into this Zoom video call and listen to this kind of conversation. That means we have a much bigger, much larger indoor floor space per capita to ensure social distancing. This is possible for upper middle class and rich people in the urban society. This is to some extent possible in the village society as well, but this is impossible in the urban slums and densely populated urban residential clusters. So according to all the mathematical modelings right now, during the lockdown, within the urban slums, we are most probably having just the opposite of social distancing. In Dharavi, there are households which have 8 by 8 size rooms and 6 taxi drivers stay there. they have got 3 taxis. 3 of them go out for a morning shift, come back, 6 of them have an evening meal together, and 3 of them go out for an evening shift. Okay, so these 6 people who have chances of getting the disease in the AC locked cars while transporting an infected person, initial imported case, for 1 hour or 1.5 hours or 2 hours across the city of Mumbai before the lockdown, are all now crammed and trapped into that slum where they are staying within that 8x8 room and sharing the toilets with 400 other people. Believe me, I got statistics from Dharavi slum where there is people have shared toilets where people are sharing somewhere around 400 to 500 people are sharing a single toilet complex facility. And the problem with COVID-19 is these cases, these people who are the service providers are mostly less than 50 years of age, are mostly non-hypertensive, non-diabetic and non-cardiac patients. So they have a more chance of having asymptomatic, mildly symptomatic or pre-symptomatic disease. So they have a more chance of spreading the disease, acting as an amplifier host within that closed community of urban slum. So what may happen is actually they transmit the disease to more higher risk senior citizens of the slum or peers having the comorbidities like hypertension, diabetes, cardiac illness, etc. And the policy that we are trying to impose in the slums, on the slums, is a policy which I would say driven by an older concept, an older act, the Epidemic Act of 1897, which was designed by the British rulers during the plague outbreak of Mumbai, which empowers the municipality to seal off the localities. Sealing off of localities creates, probably increases the problem in cases of urban slums. Okay, so what we believe is right now, there may be an increased, much more increased rate of transmission, which might not be diagnosed yet in the urban slums, which require urgent community intervention, which I believe the government of India is planning and is going to do. Okay, now, what to do in this group? Till the vaccines are not available, okay, what we have to do is we have to test more, and immediately after testing, if we find positive, we have to isolate the cases. See, home quarantining and home isolation is only possible in urban upper middle class and upper class localities. Okay, home isolation is not a solution for the urban slums. So we need to develop community quarantine centers. And you know what is the problem of community quarantine centers? The community quarantine centers, we have to be very careful that it doesn't turn into concentration camps or ghettos. You know, nobody would send your keens, your sons or daughters or brothers to a community quarantine center if you don't know what is happening inside there. If you don't know whether it is secure or not, if incidents like sexual molestation happen inside a community quarantine center, I won't send my sister to that center. If food and essentials are not properly supplied in the community quarantine center, I won't send my parents to that center. If, you know, if the center quarantine facility is not incentivized, why would a mildly symptomatic young guy having the disease go into the quarantine center? He would have earned 500 rupees per day for the next 2 weeks when he is quarantined by driving his taxi after the lockdown is over. So what we have determined is the community quarantine centers needs to be humanitarian, secure, incentivized, wage incentivized, dignified, okay, food and essentials supplied. And if you lift somebody from a family, the earning member or a senior, very, very important member of the family, who is apparently non-earning, but a pivotal member of the family like the mother or the elder sister, if you take somebody out from a family for quarantining, you have to give all these things, that is security, dignity, food and essential supply, as well as incentivization to the family members who are left behind in the household. Okay. Now there are multiple smart surveillance methods available nowadays. Even if you don't have the exact numbers of people who are infected in a cluster, to identify clusters, there are methods like sewage surveillance. So people all over the world, scientists all over the world are storming their brains and have come out with wonderful, smart studies. So people have shown that coronavirus can be identified in the sewage. And if you can identify significant burden of coronavirus from the sewage, you can say that this particular locality from which the sewage line is coming has got the disease. And you know, for community latrines like that in the slums, you can even identify which community latrines have the maximum number of burden of coronaviruses, so that you can divert more of your resources and attention to that particular clusters of the slum. There are also smart methods called pooled sampling, where you actually take the samples of multiple patients, take those samples, bring those in the lab, and actually, instead of testing each individual sample, you mix a small part from maybe 16 samples together in one tube and then test that tube by a sensitive test. If that is negative, that means the entire batch of 16 is negative. So by this clustered pooled sampling method that we have recently published, it's called a binary, it's a simple binary hierarchical method, again like this 2 square kind of thing, where we can actually save a lot of number of kits by pooling the samples instead of testing individually. Once we get a positive signal from a pool, then we again divide that pool into half and again test it by pooling. Okay, if we get a positive signal from somewhere, then we again divide it into half and we can actually reduce the number of kits to a lot extent. Okay. Then comes the early identification of high-risk individuals with mild to moderate diseases. If we can early identify the high-risk individuals with mild to moderate diseases and treat them in the community, we can reduce the burden on the tertiary cases. The problem is, when the disease came initially, for the first 2-3 months, everybody were everybody was completely running around, all the energy was dissipating in all directions, So the problem was all the cases were getting admitted to ICUs. My friends who are managing ICUs in Delhi, in Calcutta, in Chennai, they were telling that, I have 8 patients admitted in my ICU who are just sitting and eating bananas in the morning. So what then we started gradually learning is COVID-19 is not going to be a problem for us till the lockdown. COVID-19 is not going to be a problem with us for the next 3 months. We have to understand that COVID-19 is going to stay with us for at least a few years, and it is probably going to become the influenza of the next decade, until and unless we defeat it with an effective vaccine. Okay, so until unless an effective vaccine is available, till then we have to understand that COVID-19 is going to stay with us, and for fighting with that, the main fight has to be community intervention, detecting cases early, isolating cases early, detecting the high-risk cases who have mild to moderate symptoms now. I am an atheist, but if you believe in God, God has done a wonderful thing with COVID patients. God has given a leverage of 6 to 7 days after the onset of symptoms for the COVID patients to go bad. The average number of patients who require ventilator, the gap between onset of symptoms to the ventilation is about 8 days. This is a large time. I assure you that if we can diagnose early, and if we can identify who of these patients who have mild to moderate diseases have high risk, and if we can treat aggressively these high risk patients, we can significantly reduce the number of patients entering into that 6% black hole of severe diseases. And once people enter into the 6% black hole of severe diseases, till now, we have a mortality of 50 to 60%, which is very difficult for us to reduce. And once we have our ICUs and our tertiary care centers saturated gradually, this mortality rate can gradually come up. Okay, so what I believe is the strategy that we should adopt now, I would just like to share the screen again. We are on the last portion. Yeah, so what I want to mean is, in the next 6 months, intervention in densely populated urban residential clusters and the urban slums are very, very important. Number two, there is growing mistrust among people because many of our public health interventions are actually police-led. We have to change our policy, and we have to shift to a community-led, community-based organization-led, civil society-led, NGO-led, local people-led community intervention programs which are owned by the community to reduce the mistrust. Number three, we have to increase the community trust so that people come and volunteer for testing who have mild symptoms, or people give reports of their neighbors and kins who have mild symptoms for testing. Number three, people should not be afraid of getting tested and quarantined. We have to create such community quarantine centers where people feel secure, dignified, and gets incentives for getting themselves quarantined, you know. We have to have a transparent quarantine facility where the family members of the quarantined individuals can actually come to know what is going on inside. We have to have a good internet system. We can have Zoom and WebEx and all video conferencing facilities. We can have, you know, we can have celebrities, Shah Rukh Khan and Sachin Tendulkar coming and in Zoom and encouraging everybody that, okay, you are in lockdown, I am with you, and this kind of things, you know. We have to encourage people. We have to ensure that this isolation and quarantine facilities does not sound like isolation ward of the cellular jail of Andaman. This should sound like, this should give a feel like it's a temporary waiting place for getting reunited to your family, to your society. This is what that is needed. Next, what is needed is early identification of comorbidities. That takes, believe me, it takes 15 minutes for a trained healthcare worker to understand whether a person has diabetes or hypertension or cardiac disease or not, who have a significant chance of getting bad. Now you have a window of 6 days for getting bad. So during these 6 days, these people who have mild to moderate diseases with high risk can be shifted to a secondary level facility which has oxygen, and treatment is given to them so that they don't progress to severity. And a little number of these people, when they progress to severity, then we have to treat them with the available forms of therapy. I am not going into the details of the available medicines. I would say that I would encourage all the institutes who are treating COVID-19 to get enrolled in the trials, in the global multi-center, multinational trial, solidarity trial that is being undertaken by WHO. That is because we need to record the findings of each and every patient. In this trial, there is one arm which says that you can treat your patients according to your local guidelines. Okay, so you are free to treat your patients according to local guidelines. You are free to treat your patients with hydroxychloroquine. You are free to treat your patients with remdesivir. You are free to treat your patients with lopinavir, ritonavir, and you are free to treat your patients with lopinavir, ritonavir plus interferon. These are the 5 arms of the global solidarity trial. But what we need to know is we need a proper, you know, noting down of these cases, how these cases are behaving for better understanding the disease process. Okay, and next comes the role of ventilators. Believe me, ventilators are important to buy. Tertiary care centers and ICUs are important to be ramped up, but community intervention is much more important than the tertiary care. I would not say that it is less important. It is important because many of us will actually land up into ARDS and would need a good tertiary care center. But if we can actually come out of the ICUs and ventilators and take our best of the healthcare brains and community intervention brains in the community, we can reduce a large number of patients entering into the ICU. Okay, and then we have to understand that the epidemic is inevitable. It's going to stay with us, and we have to plan smartly. The last thing that I would like to say is, people like us, I have a group of friends, I have a peer, healthcare. I have a group of friends who have been, shouting in the conferences, in the rights seminars, and in the streets for demanding for universal rights to healthcare and for demanding best state-of-the-art evidence-based medicine for the most marginalized people. Nobody cared for these demands. Health has been a priority, much lesser priority for our policymakers all across the globe. It's not only for our country or our region. It has been the similar thing in many parts, except a few countries like the Scandinavian countries, etc., where you have a national health system in a part of Europe, etc. But mostly, if you see, the Indian percentage of GDP in healthcare has been 1.06% of our GDP. So what happened is healthcare has been like a neglected, malnutrited child, of eighth gravida. Okay, the girls towards healthcare. And this is the time when everybody feels that jaan hai to jahan hai. This is the time when everybody feels that healthcare is more important than the economy. So this is the time for us to bring back healthcare owned by people in the community, supported by the government, led by the smartest evidence-based science, so that it not only helps for the COVID-19, but it also strengthens the system beyond COVID-19. Because during the time of COVID-19, we have to understand, we will also see unprecedented rise in morbidity because of non-COVID cases. We will also see increase of malnutrition because of economic marginalization. We will also see bizarre kind of illnesses killing more and more people because of lack of access to healthcare. So I would end my talk here. I would like you to take it up, Professor Raychaudhuri, and at the end, I would charge a fees from you, Professor Raychaudhuri.
We'll negotiate that. Thank you very much. Thank you so much for actually making time for this, and it was a very lucid presentation. I'm sure everybody here would agree with me that it was wonderful. I mean, I hope you have some time for a few questions. I've asked everybody. If you have a question, please use the hands up button on the participant screen. Already there is one hand up, and I'm asking you to ask your question only by audio. Do not turn your video on. It gets very confusing here. There are 130 participants. And I will go by, I will ask your name and then turn on your audio and ask your question. So Surud More first.
Yeah, hi, Sayantan. Thanks a lot for this talk. It was wonderful. So my question is about the current lockdown period. So do you think until the measures that you are talking about, like setting up these community quarantine centers and so on, until they are taken up, it will be difficult to end this lockdown, or do you also support phased lockdown in different areas?
See, definitely the lockdown is a very bold decision, and it has halted the transmission to a great extent. Okay, because if the lockdown was not given, just think about the, I don't know from which city you are dialing in, just think about the local suburban trains of Mumbai or suburban trains.
Yeah, we are all in Pune, mostly in Pune here. Yeah.
Yeah. So just think of the metro, the crowded metros and buses. So definitely this lockdown has a significant impact on reducing the transmission, no doubt about it. Okay, despite of the severe, the unfortunate incidents that we have seen 8-month pregnant women walking for 150 kilometers, who was a migrant laborer and giving birth to a child, in the road. So we have seen incidents like this. We have seen a lot of the problem of not only migrant laborers, the problem of marginalization of economically challenged people. But definitely lockdown has a significant effect on reducing the transmission, number one. Number two is, see, the lockdown is not effective in creating social distancing in the urban slums. That is my sole concern. That's why I believe that during the last periods of the lockdown, as you already know, that many of our chief ministers have suggested the prime ministers to extend the lockdown in many of the states, and there has been plan of strategic easing out of lockdowns instead of completely getting away with the lockdown. So what I believe is, in the urban slums, you need to have a strong community intervention program and a very, very strategic lifting of lockdowns. And you have to also remember that in the urban slums, you have the maximum number of informal sector and unorganized sector working class who are getting worst affected by the lockdown. Okay, so it's a very difficult call until and unless you reach out there, until unless you reach out to the community, find out the disease burden and actually intervene in there. It cannot be a prescriptive process from the ivory tower. So what I believe is there is strong positive points for the lockdown, and the lifting of lockdown has to be very strategic and in the periphery, not from the central. Thank you.
Very much. Santosh, go next. Santosh Roy.
Hi, Sayantan. Nice talk. So I have two short questions. One is this: do-it-yourself ventilators have been cropping, like they are cropping up everywhere here, also on the other places in the world. So any guidelines from WHO for the, let's say, minimum clinical guidelines that they should follow? The only ones that is available is from the government of UK. We don't have any other, like those who are working on that, we don't have any such guidelines. And
do-it-yourself ventilation, right? Do-it-yourself mechanical ventilation. Okay.
Right.
Yeah.
There are many versions. So
yeah. Okay. So are you asking anything else, or should I respond?
Yeah. So one more thing is like, are you available for let's say meeting? Like if there are international group of people who are working on this to have a chat in that.
My email ID is there with Professor Raichaudhuri. Okay. We can negotiate that after the meeting. Okay. So regarding all the different styles of ventilation that are being invented all across the globe right now, you'll see that people have come out with 3D printed T-point kind of dividers, where from one ventilator you can ventilate 7 persons, right? So people have come out with pocket ventilators, smart techie guy comes out with a pocket ventilator, goes out to the street and people dying beside the street, and you just keep on ventilating them. The problem with these kind of ideas of scaling up ventilation is, number one, you would be seeing that I have been sent such video by a very senior administrative officer in the government of India, that why can't we do this? 3D printed one device. From one ventilator, you can actually connect 7 ventilators. The problem is when you have 7 patients requiring ventilation in the ICU, the 7 of them will not be of the same size, will not be of the same body weight, will not have the same lung capacity, and will not be in the same disease condition. So the conditions that are needed to be regulated in the ventilators, that is the tidal volume, there's the PEEP, the post-expiratory, the pressure, and the FiO2, the inspiratory fraction of oxygen, these will be variable for each different persons. So easing out ventilation is not going to solve critical management of ARDS. Similarly, do-it-yourself kind of ventilation kind of technology is not probably going to reduce the major mortality and morbidity burden of the disease. If I understand your question, probably I would say that scaling up of diagnostics, scaling up of surveillance, diagnosing cases earlier, quarantining cases earlier, and identifying cases with high risk earlier in the course of the illness and aggressively treating them so that they don't require ventilation should be the strategy, rather than, you know, scaling up or investing more into ventilation, which is my thought. We can discuss this out of this talk later on. Yeah.
Thank you, Sayantan. Thank you very much. There are quite a few hands up, and I'm going to quickly go through some of them, just requesting everybody to keep your questions short and focused. Shonjit next. Unmute, Shonjit.
I am.
Yes, go ahead. Yes, we can hear you.
Okay. I could not unmute because the host has been. So the question is that you mentioned about SARS, MERS, and also Ebola. Ebola is, of course, a different class. But in case of SARS and MERS, it also affected a large number of people. And at that point, it looked like probably this is the end of the world. But then finally, people managed to actually contain the epidemic. So what was the key there? Like, is it social distancing, or medicine or vaccines came in the way? Yeah, that is the question.
Yeah.
You're talking of Ebola or SARS?
No. I got your question. You were talking about SARS and MERS mostly, right? So the key was severity was more. You understand? So if you suppose in this room, out of 5 people sitting and talking, if one of us have a disease which is visibly, you know, severe in nature, I'm panting. And if the 4 rest of us understands that this is going to be an infectious disease, then probably the 4 of them will have more social distancing, or if they come to help me, will come with a mask in a more high. The possibility of these precautions will be higher if the disease severity is more. But if I have a disease with which for 5 days, I'm almost asymptomatic, okay, and I'm very mildly symptomatic, and I'm just having a little bit of running nose using my handkerchief, you know, just like, and then carrying on with my daily walk, 1 or 2 sneezes, then during these 5 days, I'm actually transmitting more number of patients. Okay, if you see the difference between SARS, MERS, and this SARS-CoV-2, the mortality of SARS is 10%. Okay, the mortality of MERS-CoV is 36%. The mortality of COVID-19 is somewhere between 3 to 4.5%. Don't go by the recent global figures, which shows 6 to 7%, because most of the experts believe that it has a problem with the denominator. If you see the Indian figure, if you see the South Korean figure, if you see most of the other figures, at least 2 weeks back from now, the mortality was somewhere between 3 to 4.5% globally. Despite of that, this has become the unprecedented problem, infectious disease, public health crisis of our lifetime. I have not seen smallpox. Okay, I was born after smallpox was eradicated. I've not seen smallpox era. I have not seen the Black Plague era. I have not seen Ebola out of Africa too much. Okay, what I have seen Nipah. In 2018, if you see the Nipah virus epidemic in Kerala, it had a mortality of 90%. There was total 23 cases, 21 out of them died. If you see the Nipah virus in Bangladesh, every year, every alternate year, there are small clusters of 5, 6 people having the disease, and almost all of them dying. If you see the mortality of Bangladesh Nipah virus, Bangladesh strain, it is between 75 to 90%. If you see 2001 outbreak of Nipah in Shiliguri, 2005 outbreak of Nipah in Nadia, and 2018 outbreak of Nipah in Kerala, we had 3 Nipah outbreaks in India. All had almost 80 to 90% mortality. But still, what is the problem? What is the best thing with Nipah? If you see the Nipah outbreak in Kerala, from the initial case, 21 got infected. So there were 22 cases, and from these 21 cases, only 1% got infected. So total, there were 23 cases. I don't believe that all these 21 cases were taken care of so stringently that they couldn't infect. It's because of the biology of the virus that once it gets replicated into the human system, human to human transmission keeps on falling. That's one reason for which Nipah has come down. And for SARS-CoV and MERS-CoV, it's because it causes more and more severe form of disease and less transmission during asymptomatic and mildly symptomatic cases. The transmission rate is lesser than COVID-19. So a combination of asymptomatic transmission, despite of low mortality, is creating havoc for COVID-19. Over.
This is very, very interesting. I mean, I'm going to have a couple more questions. There are lots of hands up, and I don't want to take too much of Sayantan's time. Girish is next. I'm unmuting you. Ask your question quickly.
Sayantan, it is a fantastic talk. Thank you very much. So my question is very simple. So this mortality rate compared to any other places like Europe or America, in India, it's very, very less. So the reasons quoted by attributed to this mortality rate is like the hot temperature in India or more resistance in India, etc. What exactly is your opinion about it?
Okay. So this is a very good question. People have been asking about this. So in India, if you see today, today's figure is somewhere around 1,000 plus mortality with 33,000 plus cases, right? I'll just open today's figures right now. Here we have 33,062 cases with 1,079 mortality. Okay, so it comes to somewhere around 3%. And if you see the global cases, it comes to somewhere around 7%, right? It's about 32 lakh cases with almost 2 lakh death. Okay. Yeah, so 6 to 7% mortality. Okay, so I believe the problem is more of a denominator problem. Okay, that I have heard from my friends from London, from New York, who had significant exposure but is having mild symptoms and have no comorbidities. They're not being able to get themselves tested. That's a problem. That can be one problem, number one. Number two, I am not buying the heat and humidity factor, because if you see reports from Ecuador, okay, Ecuador had a very significant number of cases and very significant mortality. You must have seen in the newspapers a week back when there were so many deaths in the cities of Ecuador that dead bodies were just left and people, there were less number of people to carry those dead bodies for the funeral. Okay, if you see the temperature of last 1 month in Ecuador, it's between 29 to 32. You see the humidity, it's somewhere between 60 to 70% or even more, 80%. Okay, so what I'm trying to tell is, see Iran. Okay, so it's very difficult to say that, you know, Myanmar or Thailand have cooler temperature or lesser humidity, or Iran has cooler temperature, or Ecuador has cooler temperature than India. So, and there is another theory. There has been a publication which shows that probably Indian gene has a mutation which the virus doesn't affect much. I have gone through the publication quite carefully. I don't believe that we have a pan-Indian gene signature. India has a more genetic variety than the entire Europe. Okay, so there cannot be one single genetic signature which is there. There may be God's grace, but unfortunately, I have grown up to be an atheist. But you know, I feel that the mortality across the world is somewhere around 3 to 4.5%. There is a problem of denominator. There is a problem. Okay, I missed one point. Problem of aging population. In Western worlds, where the reproductive rates for the last few decades have been lower, there is a more aging population. With significant nutrition, there is more obese population as well. Okay, so this aging obese population with significant number of non-communicable diseases like diabetes, hypertension, etc., may be also a factor. So till now, it will be speculative from my side, both to accept that India truly has a low mortality or to theorize that this might be a reason for a low mortality. It would be speculative. I would refrain from that, but I would definitely like to, I'm already engaging with people. I would definitely like to investigate that if it is happening, why is it happening? And we need to have more data on that. Thank you for your question.
Thank you, Sayantan. You've been very energetic. I hope, can you take a couple more questions? We have 5 more hands up.
Yeah, I'm working, okay till next 12 minutes. 5:30 I have a call. Yeah.
Okay, right. RK Jain, please go on. I'm unmuting you.
Hi, can you hear me?
Yes.
Yeah, so it was a very nice and informative talk. So in the beginning, you mentioned about this binary testing, right? I want to ask you, what about how do you take care of the false negatives in the binary testing procedure? And my second quick question is that you didn't mention anything about flattening the curve in your entire talk. Can you quickly comment on that as well?
Okay. So by binary testing, you mean pool sampling, right?
Right, right.
So see, there has been a lot of confusion regarding pool sampling. Pool sampling is a technique which has been as old as the modern medicine itself. You know, pool sampling initially started with the military recruits of the UK, of the British Army, for diagnosing sexual transmitted diseases in the military. For diagnosing diseases like syphilis, gonorrhea, etc., where, you know, multiple samples were taken, and, you know, the number of kits were less. The viral tests were, suppose, from the batch of 5 test tubes, a little bit of sample was taken from each test tube, and viral test was done. If it is positive, that means 1 out of 5 is positive.
Right.
Okay, or 5 out of 5, or 4 out of 5. We don't know. Then individuals were again tested. So this was a primary style of pooled sampling. So there are various methods of pool sampling. Some people do it like this, you know, they take the swab, they collect the swab, suppose throat swab from a person, and put it in one big jar. Collect another throat swab from another person and put it in the same jar. Collect another throat swab from, so like 10 samples are pooled in the same jar. And you know how these swabs are tested normally. If I collect swab from one of the participants here, and I put it in a jar containing a medium called VTM. VTM means viral transport medium. Okay. So what we do, we take this in the laboratory, we shake it vigorously in a machine called Vortex, and then we discard the swab. We don't test the swab. The viruses in the swab goes into this viral transport medium. Okay. And we take a little part of this medium, then we process it, we filter it, we centrifuge it, okay, and we take that portion in which the viral RNA is supposed to be concentrated. And then we do a test called PCR test, RT-PCR. I'm not going into detail. The basic concept is, as the viral RNA can be very small in number, either you have to amplify the signal, or you have to actually amplify the target. Whenever we see something by microscope, we don't amplify the target. We amplify the signal coming out from the bacteria. Whenever we do something called culture, blood culture or urine culture, we actually amplify the number of bacteria. That is amplification of the target. Okay. So PCR is amplification of the target RNA so that it gives a significant signal. Okay, and we have a definite coefficient of amplification. We can realize that if there is this much amount of signal after 60 cycles of amplification, so 60 cycles before probably the RNA load was this. We do this kind of a calculation. Okay, so in binary sampling, there is a possibly this pool sampling. What we did a mathematical model with a renowned mathematician from Mumbai. He is Mohan Maharaj, Mohan Mitra. We developed this binary sampling along with him and his colleague Sibaji Pratim Basu, who is a probability teacher in TIFR. So Riddhi Pratim Basu, sorry, Riddhi Pratim and Mohan Maharaj. What we did is, we were just trying to find out what will be the best way in which we need the minimum number of kits, as well as we reach the person from who is diagnosed, who is infected. Okay. The problem is, if we put the swabs in a common medium, in the slum, suppose in the slum, the healthcare worker has gone, takes swabs and 10 swabs are pulled into one medium, and all 10 swabs are mixed. Okay. And then we test from this medium. This is also pooled sampling, but this would tell that somebody in this 10 is infected, won't lead to the individual person. Instead of that, what we have designed is, our model is, we would collect individual samples, okay. Now, we would collect geographically clustered samples. Suppose when we take a box and we collect 32 samples from close households, from 4 or 5 close households in Islam. The 32 samples are labeled individually and are individual samples. Now we bring that 32 samples in your laboratory. Okay. Now how we do the pooling? We divide these 32 samples into 16, 16. Okay. Now from these 16 samples, we take in one test tube, we take minute quantity of, after mixing the samples thoroughly, we take a little bit of quantity. Suppose, let me say 1 ml from each sample. Okay. We have taken about a VTM medium of 25-30 ml in each sample. We are taking 1 ml from each. Okay. Now we filter it and we take the filtrate so that there is concentration of that sample. Okay. Reconstitute the filter and then do the RNA testing. If there is positive, it will come as positive. If there is negative, now your question is false negativity. False negativity will reduce if we reduce the number of samples pooled. So there has been pooled sampling algorithms done with various other viruses on respiratory viruses, HIV in serology. There have been different pooled algorithms which show that we can use very less number of kits. Suppose we have 10 lakh people here. We collect 10 lakh sample and we do one RT-PCR. Negative, then negative. Nobody is infected. We can't do that. That will lead to false negative. And we have seen that if we keep somewhere the sample between 10 to 16, ICMR has said that 5 samples are maximum to reduce the false negative. They have become more stringent just to ensure that nobody is false negative. We don't miss positive cases. Okay. We are telling that somewhere between 10 to 16 samples we can pool, and if we filter it properly and we use a very good sensitive kit, we can eliminate false negativity to a great extent. Okay, so over. And flattening of the curve, I didn't get your question very well. If you repeat, that will be better for me about flattening of the curve.
Can I go on to the next question? Because flattening the curve, to explain, will take a long time. And that's something that I think is available on in the public domain. People can talk.
I didn't get the question very well. Yeah.
Can we take a last question because you're running out of time from Indulekha, who's waiting.
Yeah. Hello, sir. Thanks for an excellent talk. Since you were talking about mathematics, if you look at the R0, do you find any dependence on the population density? Has it been, separately looked at for different regions, like proportional to the square of the population density? The second part of the question is, I'm talking from Kerala, and right now we have got COVID, dengue, and monkey fever going on there. So again, I would think because of population explosion, is there any connection between that and the zoonotic jump, etc.? And between SARS and MERS, 10 years, then 8 years. So what next? The prognosis for such jumps.
Okay. So your first question is on R0, right?
Yeah.
So can you see my slide?
Yeah.
Yes.
Am I blocking the slide with this Zoom window or it's
No, it's all right.
Okay. So it was a nice question, Indulekha. So R0, there is a basic reproductive number is dependent on 3 factors. I deliberately avoided this jargon for this learned audience of non-biologists, but we can discuss this. It depends upon 3 factors. One is transmissibility of the disease. Number 2 is average rate of contact. Number 3 is duration of infectiousness. I would explain if I have a few minutes to explain this. Transmissibility means, suppose 5 of us or 10 of us are gathered here for a reunion. Okay, we are staying together, having some drinks. We are in a small hostel room, typical of these universities. Okay, and one of us is infected. None of these people have any immunity against it. Okay, so the transmissibility, the probability of infection is high if nobody has any immunity. Okay, now just consider that this is not COVID-19 but HIV. Okay, one of us has HIV, none of us is immune to HIV. But what is the transmissibility here? if the infected person do not have sharing of needles, if suppose we have a party going on where we share smokes, we share marijuana, we share alcohol, but we don't share injectable drug needles, then the transmissibility is 0, number 1. Number 2, if we don't have unprotected sex among these party people, then the transmissibility becomes 0. If we don't share blood or serum or any body fluid, okay, the transmissibility is 0. So it depends upon the disease and the mode of transmission, as well as the level of immunity here in people. Suppose if we talk about measles, it has very high R0, but many of us are either vaccinated with MMR or had measles in our childhood. That's why we will not get infected. So this is transmissibility. Definitely the probability of infection will be more if we have a denser population. This is first question. Number 2 is, see, the average rate of contact, again, comes the population density. The average rate of contact means we spent almost 1.5 hours now altogether, maybe 100 audiences with me, but we are not in a room, we are in the Zoom space. Okay, so despite of possibility of me being infected, the average rate of contact is 0. Okay, you know what kind of thing can infect via Zoom? Do you have any idea? It's yawning. You know, it would have been a boring talk and everybody could see everybody yawn. So we could have an infection of yawning, you know, via Zoom as well. So average rate of contact also reduces if the population density decreases. And the third point is duration of infectiousness. As I told you, COVID-19 has a duration of infectiousness of about 2 to 3 weeks, where in the beginning you are infectious when you are asymptomatic. Then when you are even mildly symptomatic or pre-symptomatic, you are infectious. When you are symptomatic, you are infectious. When you die, after that also, if your respiratory secretions are there all over the dead body, then also it is infective. So the duration of infectiousness is also significant for COVID-19. Okay, and if we really have a good drug, as Didier Raoult, the French infectious disease physician, has claimed in his study that hydroxychloroquine and azithromycin significantly reduces the shedding of the virus. If that holds good in other trials as well, then we can understand that this is a good drug, or there can be some other good drug which reduces the shedding of the virus even during the course of illness. That decreases the D. Okay, so this is how we can reduce R0. This was the first. I forgot your second question, actually. I'm sorry, I was speaking too much.
That is regarding SARS, MERS, the time interval was 10 years. Then MERS to COVID is 8 years. And population is exponentially increasing.
Yeah, I'm not truly I'm not an expert on this. I don't know this. I'm really sorry. I can't.
For zoonotic jump.
Well, there is the zoonotic link. Definitely, there is a zoonotic link, probably, because till now the evidence that we have, we are not sure about the conspiracy theory of laboratory designed virus, etc. Till now we don't have, but still now we have enough evidence to show that it's closely related to some bat coronavirus. So there is high possibility of a zoonotic link as well. But regarding the timing, I'm really sorry. I don't have any clue. Yeah. But before you end, Professor Raichaudhuri, before you end, I would charge my fees. You have to allow me 1 minute for charging fees.
Okay, right. Go ahead.
Okay. So, yeah, so I've noted it down, what I would charge from you. Okay. So, I am very much interested in popularization of science. Let me stop sharing my screen again. Am I back?
Yeah.
Yeah, so we run, a few of our close friends run a vernacular popular science website called bigyan.org.in. It's bigyan.org.in. It has the largest footfall of Bengali speaking students and teachers from India and Bangladesh and other parts of the world, in which we tend to, we have started with Bengali because our vernacular, our mother tongue is Bengali. We are happy to help or participate in other popular science vernacular initiatives as well. And we would request the scientists over here to, because it was astonishing to find the large Bengali mafia that you have in your institution.
Yes, we will request a lot of people here to contribute to your website. Yeah. I can talk to you offline about this. And if you are interested in actually extending it to other languages, I have actually been to the Vigyan.org site. I know it is excellent. If you want to extend that, we will certainly support you.
Yeah, and the second part is, and the second part is, you know, you are the group of astronomists and astrophysicists, you know, the brightest of the lot. And till date, we have so high penetration of using the star positions, using the positions of stars and galaxies for predicting people's future. The buy-in for astrology is so high in India. Okay, I have never studied astrology.
But we don't do astrology though, Sayantan.
No, just. I know I'm not accusing you of astrology. I'm accusing you of not significantly bringing in star signs to prove that future cannot be predicted by star signs. You know?
I hope my colleagues are all listening. This is a big, of course, confrontation between astrology and astronomy. And for popular science websites like yours, this is a very good thing to take up and convince the people of the country how astronomy is a true science and astrology confuses things quite a bit. I promise you, I pay you more than your fees in this.
Yeah, because Professor Raichaudhuri, we have the same problem. You know, we try to practice evidence-based medicine, and we get defeated by gemstones and roots, and you know, we get defeated by bizarre non-evidence-based. I would like to prescribe gemstones to my patients if that can cure HIV. I deal with most difficult multi-drug resistant and extensive drug resistant tuberculosis patients. Believe me, I would give gemstones to everybody if that would really cure. So what I want is, astrology is a science, is a method which is challenging evidence-based medicine very, very significantly. And with these kind of pandemics coming in, all sort of misinformation in WhatsApp, you know, there are advertisements of immunity booster, immunity booster fruit, immunity booster juice, immunity booster drink. Now there are immunity booster gems. Okay, so being astrophysicist and astronomist, I would request you that provide evidence. Okay, provide evidence. If that works, I would prescribe to my patients. If that doesn't work, I need to see that why doesn't work. So
thank you very much. I mean, everybody, I see more hands are coming up now in this discussion, but I would like to stop this. There are many of my colleagues here who are present, who are have actually done a lot of science popularization and have dealt with astrology versus astronomy and things like that quite a bit. We have very strong movements trying to confront this. I would invite everybody who's here to take part in this discussion now, if possible, and tell us what we can do to more actively combat this kind of astrology. Currently, with this pandemic, I think what has happened, of course, WhatsApp University is the biggest university, and a lot of this misinformation is going out. Actually, quite influential people are doing this now. I mean, you know, has been tweeting nonsense. So we certainly have to combat this. I don't know. I don't want to detain Sayantan from his medical duties any longer. So unless you have any other things to bring up, we will conclude this session and we can talk offline about this. I will circulate to this audience the email address of Sayantan, if that's all right. You said that you can take questions from him.
Yeah, preferably the Gmail one.
The Gmail address, yes. I will, and of course, I will also circulate my Gmail address to everybody. Ask us questions, and if you particularly have anything to contribute to what Sayantan raised towards the end, I think was absolutely wonderful.
It would actually help evidence-based medicine very much.
Thank you. Thanks very much. And thank you for the 130 people who actually stayed till the very end of today's discussion. Thank you very much. And as Indulekha started applauding, Zoom actually lets you applaud. Go ahead and applaud. Thank you very much.
Thank you. Bye-bye.
Bye for now.